I'm going to present on an interesting case of a recurrent tongue abscess that was secondary to a foreign body, which we manage at New Somerset Hospital. Consent was obtained from the patient, and all my content is referenced. So my case is of a 26-year-old female who is originally from Zimbabwe, and she had no comorbidities. She reports that at age of 6, she fell and bit her tongue, after which she had an anterior tongue abscess, which was successfully treated with antibiotics in Zimbabwe. Then in 2020 and in 2022, she had recurrent abscesses on the same area. And on both occasions, she was successfully treated with antibiotics. That was also in Zimbabwe. Then 3 months ago, she had a third recurrence of the tongue abscess while she was in South Africa. And an incision and drainage of the abscess was done under local anesthesia. And the patient was down referred to our institution for antibiotic continuation. So we did a lateral X-ray, and that showed that there was a foreign body that was embedded in the anterior tongue. The patient improved on antibiotics and was discharged home on oral antibiotics. And we gave her a date for incision and removal of the foreign body. We also decided to do a CT scan on the day before the surgery for operative planning. So basically, the CT showed a foreign body in the right anterior aspect of the tongue, which had the morphological shape of a tooth that was lying at about 4 millimeters from the ventral surface of the tongue. So we took the patient to theater, and under general anesthesia, the right ventral surface of the tongue was incised vertically by about 1 centimeter, and blunt dissection was done. And we removed a rotten, foul-smelling tooth. The tongue cavity was washed copiously with betadine and saline. And the patient was discharged the next day on analgesia, antibiotics, and a mouthwash. Unfortunately, the patient never returned for follow-up. So my presentation today will be focused on lingual abscesses. So a lingual abscess is a rare disorder, and a lingual abscess recurrence is so rare that it has only been described twice in the literature. And unsurprisingly, the immunocompromised patient is at greater risk for infection. For anterior lingual abscesses, predisposing factors include most commonly impaction of foreign bodies, whether it's a fish bone, a toothbrush bristle, or a toothpick, poor oral hygiene, that is poor dental and salivary health, heavy smoking, and local trauma. For posterior lingual abscesses, the most common factors are lingual tonsillitis and infected thyroglossal duct cysts. Usually, protective mechanisms of infection of the tongue include the high vascularity and lymphatic supply, the tightness of the tongue musculature, the integrity of the squamous epithelium covering the tongue surface, and the constant tongue mobility, and also the continuous turnover of saliva, which is a natural bacteriostatic and lubricating process for the mouth. If any one of the protective mechanisms is defective, the pathologic organism can pass through to the tissue and infect and damage the underlying tissues, thereby forming an abscess. The main pathogens causing lingual abscesses include streptococcus, staphylococcus, gram-negative rods, and anaerobes. In addition, some rare organisms have also been reported, such as Mycobacterium and Actinomyces. An anterior lingual abscess is easier to diagnose. Patients usually report odynophagia, dysphagia, a painful tongue, tongue swelling, limitation of tongue motion, and dysarthria. Base of tongue abscess usually presents with referred otalgia, dysphonia, acute dysphagia, and severe pain on the suprahyoid region and during tongue protrusion. A posterior lingual abscess increases the potential for upper airway obstruction because of tongue parenchymal edema, thereby obscuring the oropharynx. And anteroventral tongue abscess with sublingual space swelling also has the potential of airway obstruction in association with epiglottitis and edema. So the differential diagnosis of lingual abscess according to available literature includes actinomycosis infection and acute epiglottitis, neoplasm, arteriovenous malformation, cystic lesion, hemorrhage, infarction, pseudoaneurysm of the lingual artery, giant cell arteritis, angioedema, while an abscess at the base of the tongue should be differentiated from lingual tonsillar abscess, intralingual thyroglossal duct cyst, and lingual thyroid cyst. So careful history taking and physical examination, and that includes an oral lingual palpation, can help provide the exact diagnosis. Lab testing provides further information. Most patients usually present with normal levels of white blood cells or slight leukocytosis. One can do needle aspiration to confirm the diagnosis from an MCS or cytology if malignancy is suspected. A plain film X-ray is a cheap option to look for retained foreign bodies in a resource-limited setting. Contrast-enhanced CT scan helps diagnose a posterior lingual abscess and cellulitis and other possible lingual masses. However, if the disease can be clearly identified and concomitant deep neck infection is not suspected, then there is no need to do a CT scan. MRI is another valuable tool for evaluating soft tissue structures and abscesses. However, it is time-consuming, expensive, and not suitable in a resource-limited setting. It is also time-consuming and not suitable for a patient with impending respiratory failure due to airway compromise. We also have ultrasound, which is another option. So basically, ultrasound is non-ionized, non-invasive, and cost-effective. A hypoechoic lesion surrounded by a hyperechoic ring is the typical finding of a lingual abscess on ultrasound. And furthermore, the ultrasound can differentiate a cyst, lingual arterial aneurysm, and abscess. However, the limitations of this technique are as follows. The results are dependent on the operator's experience, and this technique must be performed intraorally, which is uncomfortable due to pain, and it is hard to assess the deeper lesions, such as the posterior part of the tongue. The cornerstone of lingual abscess management includes, firstly, maintaining the airway, secondly, draining the abscess, and thirdly, giving antibiotics. Maintaining the airway is important, especially for posterior third lingual abscesses or abscesses that are located at the base of the tongue. However, if an abscess forms in the anterior part of the tongue and it is concomitant with sublingual space infection, the risk of impending airway obstruction is high, and patients presenting with signs of airway compromise require immediate airway management and potentially tracheostomy. Draining the abscess is described in two methods, needle aspiration and open surgical drainage. Both techniques can be performed via a dorsal or sublingual approach, while surgical drainage is preferred at the base of the tongue or floor of the mouth to avoid injury to the lingual artery. The advantage of needle aspiration is avoiding a GA and exacerbation of airway edema by endotracheal intubation. On the other hand, surgical drainage can have more advantages, including a large amount of pus drainage, tissue biopsy if malignancy is suspected, prevention of reinfection due to open drainage, and dressing of the wound. So empirical antibiotics should be broad spectrum to cover the possible organisms originating from the oral cavity and oropharynx, which usually comprise gram-positive, anaerobic, and gram-negative bacteria. Amoxiclav, clindamycin, or metronidazole plus cephalosporin combination are good initial antibiotics. And antibiotic treatment should be adjusted according to the culture and sensitivity of the pathogen. So the following is a flow diagram from a systematic review by Wilson and Ashford for lingual abscess workup and management. A patient presents with a tongue swelling plus minus pain. If there is airway compromise, the airway is secured by endotracheal intubation, usually using fiber optic guided methods if needed, or by tracheostomy. CT imaging is done, and if there is no radiologic evidence of a collection, antibiotic coverage and airway monitoring is done. However, if an anterior or posterior lingual abscess with sublingual or deep neck collection with surrounding tissue involvement is seen, surgical drainage, antibiotic coverage, and airway maintenance must be done. If the airway is not compromised, but there are systemic features and or evidence of spreading infection, for example, fever, neck pain, and trismus, a CT scan needs to be done and the abscess drained. Otherwise, aspiration, plus minus ultrasound guided, and or incision and drainage, antibiotic coverage, and ongoing airway surveillance must be done. Lingual tuberculosis has been described. It can present as a cold abscess. Vishwa Karma and colleagues reported a lingual tuberculosis patient who had a non-painful tongue abscess for 3 months. TB of the tongue is the most common site of oral cavity tuberculosis, and this may be primary or secondary with pulmonary TB. Both immunocompetent and immunodeficient hosts can be infected by mycobacteria. The lateral border of the oral tongue is the most commonly affected site, while the base of the tongue can also be affected. The lesion can present as a non-painful tongue mass, an ulcer, a fissure, a tuberculoma, diffuse velocitis, and a non-healing tongue lesion. The diagnosis is based on tissue biopsy, and in this case, it showed epithelial cell granulomas with Langerhans type of giant cells, and MCS of the pus demonstrated acid-fast bacilli. The patient was placed on anti-tubercular treatment with 4 drugs, including rifampicin, isoniazid, pyrazinamide, and ethambutol. The response was dramatic, with considerable decrease in the size of the swelling of the tongue and fever after 1 month of anti-tubercular treatment. There is only one published case in the literature from Spain of recurrent lingual abscess secondary to a foreign body. It is the case of a 56-year-old African male with type 2 diabetes. He had a motor vehicle accident 26 years earlier with a complete section of the anterior third of the tongue, and he reported impaction of a toothbrush bristle during his daily cleaning of the tongue surface, subsequent to which he suffered 2 episodes of lingual abscess 1 year apart. CT scan of the oral cavity confirmed the presence of a multi-lobed abscess in the middle third of the tongue related to a foreign body with plastic density. The lingual abscess spontaneously drained through a dorsal dehiscence on the tongue surface. The foreign body was removed through a surgical opening through the spontaneous dorsal dehiscence, and the patient was discharged on oral antibiotics with no reports of recurrence. I'm going to show a few interesting published cases of teeth embedded into the tongue. The first two cases are from Brazil of young males with teeth embedded into the tongue following firearm trauma to the face, whereby tongue lacerations were sutured at a local hospital a few months earlier. In both cases, x-rays were done, and in both cases, incision and removal of the teeth was done under local anesthesia, using a dorsal approach for the first case and a ventral approach for the second case. And in both cases, no antibiotics were given, and neither of the patients returned for follow-up. Then we have a case from India of a young female who 6 months before fell, bit her tongue, and her incisor tooth went missing. The patient did not seek any treatment, and the bite wound healed. And since then, the tongue had been constantly painful. An X-ray was done, and the tooth was removed under local anesthesia with no post-operative sequelae. Then we also have a case from Ireland of a 10-year-old girl who fell 9 days earlier, sustained 2 lacerations on her tongue, and fractured her incisor teeth. An X-ray was done, and 5 retained tooth fragments were removed under general anesthesia. Recovery was said to be uneventful. So, in conclusion, a lingual abscess is a rare disorder, and a lingual abscess recurrence is an exceedingly rare disorder, and one must have a high index of suspicion for an impacted foreign body, especially in a child. Those are my references. Thank you.
Thank you very much. That was an unusual case, huh?
Never been seen in this web in Africa before.
Yeah. Where was it that no diagram written up?
It was from Australia, if I'm not mistaken. 2013.
2013.
August 2013.
Yeah, so you can't go to 2023.
Yes, August 2023.
2023, yeah. I mean, I think the only effect that I've seen are we had a patient where they looked at the kind of get infected. So that's the only case that I've seen which is coming in with airway obstruction that involves tongue piercings. Do they? Oh, abscess. Have you had an abscess before? I mean, you didn't look up on the piercing.
I looked at all sorts of foreign bodies, and tongue piercings have been described, but those are case reports. There's no systematic reviews that have been done.
But there have been case reports of abscesses.
Yes.
Around that.
Yes.
Okay.
There's only been 6 published case reports of teeth impacted into the tongue.
Really? Wow. Sure. Thank you.
Nice presentation. Nice.
Yeah, and the big concern is going to be airway. You went it on time.
Dr. Pretorius, are you on the call?
Yes, I am.
Yeah.
Well presented, Hervin. Well presented. I think the only thing that I can add was my concern was when we did the incision and drainage in theatre that because the tooth has been there for 20 years, that it might be sort of fragment. And there was a little bit of a tooth root that stayed behind. So I curetted the cavity to make sure I got everything out. And also I had a concern of maybe a biofilm or a pseudocapsule from all the previous abscesses. So that's the only other thing that I just, before I irrigated the cavity, I scraped with a curette to make sure that I could break down if there was any biofilm, because it was quite offensive once we went into the cavity. And then the ultrasound is actually can be helpful for posterior tongue abscesses if you use it externally. Obviously, intraorally, it's not so useful. For the anterior tongue abscesses, I think you can just palpate it. It's not that necessary. When we saw initially, she had quite a bit of edema of the tongue. So localizing the foreign body was a little bit difficult, which is also why we did booked the CT scan electively. But by the time she came back, the sepsis had settled and you could easily palpate it on the ventral surface of the tongue. But yeah, well presented, Hervin. Thank you.
Is there anyone in the audience who has ever encountered a tooth embedded in the tongue?
You so ask that first.
I'll have it back with them.
Yeah, yeah. Oh, most unusual.
They are the ones who down refer the patient. They are the ones who down refer the patient.
Yes. Interesting. Well, thank you very much. The most instructive, yeah. Okay, that's great.
Thank you, everyone, for attending our meeting. Our next meeting is next week on Wednesday morning. Thank you, everyone, and have a nice day.
Good, thank you. Our new resident from Pittsburgh arrived in Cape Town. She probably learned. Right. And you made a good friend of some of the park. Resident will come to you, you make one, they contact them. Okay, it's really. Remember, it could be free accommodation in the States.
Yeah.
Well, go to United States. With hotel. Yeah, in Pittsburgh, a few days. Right. Go with. Yeah. Big mouth. Sure. It's still sharing this. They'll come meet the.